Disclaimer: the content of this episode is intended for general information purpose only. For medical advice, please consult with your healthcare provider. Hi, everyone. I'm Michelle Jobin, and you are listening to Time to Talk, a podcast for caregivers. This podcast is dedicated to helping family caregivers in Ontario. Through expert tips and resources, you will gain knowledge and validation for the ups and downs that come with caregiving. More importantly, you'll learn that you're not alone. It's so important to take this time for yourself. We're glad you're here. Today, we are joined by Dr. Patrick McGrath. Dr. McGrath is a clinical psychologist and Emeritus Professor of Psychiatry at Dalhousie University. He is also the founder and CEO of a new startup, 90 Second Health, which is developing a new way of delivering health information. His extensive career has included being a clinician, researcher, administrator, and social entrepreneur. He has experience working with all forms of anxiety, depression, OCD, and PTSD. Dr. McGrath's research, mentorship, and healthcare leadership have been recognized by an appointment to the Order of Canada and election to the Royal Society of Canada and the Canadian Academy of Health Scientists. Dr. McGrath, thank you so much for being here with us today. It's an absolute pleasure to have you on the show.
Well, it's wonderful to be involved with your organization.
We really, we're here today because we want to really create a space on Time to Talk where Ontario caregivers can connect and share and hopefully gain some knowledge and understanding. And I hope through our conversation today, we can gain a little bit more insight into PTSD in caregivers, your experience and what you have to add to this from your professional perspective. So to begin, what is the definition of PTSD?
Well, I'll give you my definition of PTSD, but there's also the DSM-5, that's the Diagnostic and Statistical Manual of the American Psychiatric Association, and there's also the International Classification of Disease. But PTSD is a mental health problem that resulting from experience of a significant trauma. The result of that is ongoing disturbance in memory. And it's almost as if you're still there in the situation, so that you feel that this situation is revisited on you, or the situations. And what happens is that, let's say that you witness if you're in an accident, or if you have a violent attack against you, this memory of this situation comes back either in flashbacks or in bad dreams, or in just these snippets of feelings of uncomfortableness, may come back with symptoms of depression, anxiety, anger, also a sense of impending doom. And very often, person is on edge. They're hypervigilant. They're ready for danger, even though at the present time no danger is existing. So it's a trauma, and a trauma can be something that you experience directly, something that is experienced by a close family member, something that you observe. But these are life-threatening traumas usually. And that's really what it is. And it's a disorder that causes widespread mental health problems. But in some ways, it's not a mental health disorder. It's a disorder of memory, because your memories, the PTSD memories, are very different than the normal, miserable memories that we all have. Something bad happens to me, I have a long a memory for it, and I don't feel, it's not a very good thing. Say a very close family member dies, and you're with them when they die. You'll never forget that, but it doesn't affect you the way a PTSD memory is. I know that it's in the past. I know that it's finished, it's sad, but it doesn't trigger anything like what a PTSD memory does. The other thing about a PTSD memories is that we avoid them. We try actively to avoid the memory. We often try and avoid the situation that reminds us of it. And we try and stay away from those things. Makes sense because it's not very comfortable, but it also perpetuates the problem.
And it's really good to hear your definition and of course, like you said, the clinical definition of PTSD. I think it's a term that's maybe become it's perhaps thrown around a little bit glibly in popular culture sometimes. So it's good to have that understanding, and also that, you know, there is a neurological distinction between a really bad memory and what is PTSD, and maybe the state of hypervigilance or depression or things like that arise around this. And when we're talking about relating specifically to caregivers, and even more specifically to unpaid caregivers, somebody that is caring for a loved one, what is the nature and the symptoms of PTSD that you have seen in this particular group of people?
Well, the symptoms are the same no matter what or similar, no matter what the cause of it is. But that's the emotional symptoms, the flashbacks, the bad dreams, the avoidance, the being on edge, that hypervigilance. Those are the types of symptoms that are very common, and they are sometimes quite pervasive and quite interfering with people's lives. We did a survey of about 600 parents of kids that had serious neurodevelopmental disorders, and about half of them qualified for PTSD. Now, not all of the events were from their caregiving, okay, but some of them were from accidents or sexual assaults that had occurred independent of their caregiving. But there were also a very high level of events that had occurred from caregiving. Caregiving, you may witness, for example, your loved one in a very significant medical crisis, or they might be aggressive, and you may be fearful of your well-being in your life because they're trying to attack you or somebody else. Those are the types of things that occur from caregiving, and the medical trauma sometimes is not that they're dying, but sometimes they have to have procedures that are very, very frightening. And so, or you may learn about them, they're in the emergency room or they're in the ICU, and you learn about how close to death they were. Those are traumas that can contribute to PTSD.
Caregiving is a rewarding journey, but it can also be incredibly challenging. 90-Second Caregiver provides short, practical tips to help caregivers manage their stress. Whether it's a quick break, relaxation exercise, or a few minutes of self-care, the tips are designed to help you manage stress and maintain your mental health. 90-Second Caregiver delivers health information, tips, and advice related to the caregiving experience and caregiver mental health straight to your inbox each week. Take care of yourself. Subscribe to the 90-Second Caregiver at ontariocaregiver.ca.
And you mentioned that, you said in this particular group that you surveyed, you said about 50%.
Absolutely, just over 50%. Over 50%.
Over 50%.
And we didn't select them on the purpose on trauma. We just asked them to volunteer for a survey about being a caregiver. Wow. And so that's a bit high from some other surveys. It's a bit lower. And I'm sure that it varies. It varies both in terms of the degree of trauma in the caregiving. It also varies in terms of the sensitivity. Some people get PTSD easier than others.
Right.
There is a genetic component to it, and we don't completely understand the genetic component, and it's not just one gene like it is for eye color or things like that. It's fairly complex, but there clearly is a genetic component. The other thing is that in most studies, women are more likely to get PTSD. And again, we don't know exactly why, and there's some debate about that, but most studies find that.
I can definitely understand as a parent myself, why in that particular group, when you're talking about parents taking care of children that have those particular conditions, I can understand the potential for that higher percentage, but it is completely understandable that this would be something that occurs relatively frequent, given what caregivers can encounter in their caregiving journey. But also good to know that there's that particular potential genetic component to it as well.
And it's not a matter of weakness or somehow vulnerable. They're not more vulnerable they're perfectly, people are perfectly normal who have PTSD. They're not crazy. They're not weak. They just have had trauma, and they happen to have the genetic component, and maybe they've done some things and that have not encouraged it. Like avoidance does not help PTSD.
Well, that's good to know, and it's really important to underline for people that might be going through this that this is not their fault. This is not a weakness. This is a very likely occurrence given some of the situations that they are experiencing as caregivers.
And it interferes with caregiving.
Which actually brings me to my next question. So I'm so glad that you mentioned that. How does PTSD affect caregivers and the important work that they do for their loved ones?
Well, it changes imagine if you're prone to depression because of PTSD, or you're tending to be getting more angry, and caregiving is a very demanding situation. Many caregivers lack sleep. And if you get further problems with your sleep because of your PTSD, then it really is a mess. So, when I was a caregiver and I cared for my wife as she was dying from cancer, it was a time-limited situation, but it was extremely, extremely severe. And I was just exhausted all the time because I had to be vigilant. But if I had been hyper vigilant because of of PTSD, it would have been even more difficult. So it interferes in all sorts of ways. PTSD just takes over people's lives and makes it very difficult. Now, the caregivers that I've known with PTSD are amazing people, and they persevere in spite of this. I think the big mistake they make is they say, well, I have to focus on my loved one, my person who I'm caring for, instead of focusing on my own health. But it's very much like what they say when you're up in an airplane. You're in an airplane, the first thing they say is, oh, here's the safety things. If there's a lack of oxygen, you put on your own mask first, because you're not going to be of much use if you can't breathe to be able to help your child or another passenger. So you put on your own mask first. And caregivers often, they say to themselves, well, my husband or my wife or my child, they're more important. And so, I can cope with all this. But it's probably, if they have PTSD, it's probably interfering with their caregiving in so many different ways, in their patience, in their ability to think, because when you're depressed and sleep deprived and angry, you just don't function the same way.
Is it something that can potentially carry on, say someone is caring for a loved one that does pass away? Does the PTSD remain?
PTSD does not spontaneously disappear. And just because people have PTSD from stressors, from trauma that occurred 5, 10, 15 years ago. And so it does not disappear when the stress gets less. Some of the symptoms may get a little bit less, but it will not disappear. And it will be a legacy, a terrible legacy of caregiving. Caregiving, we want to be able to think of our loved ones or the ones that we've been caring for as very positively when they leave, when they die. But that maybe you can't you're not going to get better just because your loved one is no longer being cared for.
Which I think is why the next question I have for you is particularly important because of that. Let's talk about medical and psychological treatments for PTSD. What can you propose that might be effective in these areas?
Okay, so there's been actually a lot of research, partially so much research because many veterans have come back from wars with PTSD. So there's been a lot of research on that over the last 15, 20 years. There's two general classes of treatment: the medical treatments and the psychological treatments. Now you can do both of them together. The medical treatments are mostly the antidepressant medications, like the SSRIs, Paxil or Prozac, and all those types of drugs. They are moderately effective. They can be helpful, okay? And they're easily available through family doctors, and so it's something that is widely used, and these are good treatments, okay? And they've been shown with randomized controlled trials to be helpful. But the most effective treatments are specific types of psychological treatments. These are treatments that are what we call trauma-based treatments. They include treatments that are called exposure treatments, and there's 3 or 4 different types of exposure treatments. And they also include one other type of treatment that is also an exposure treatment, but usually doesn't go on that name. So one of those treatments is called EMDR, in which you focus your attention on a specific point, and then you change it and you bring in the thought and so on of the trauma. And then another type is is cognitive behavior therapy for cognitive therapy. And what they do is they often a group, and you have a discussion of your traumas and how you can manage it with specific things. But the most widely used and the clearest evidence for efficacy are the exposure treatments. And there's 3 types of exposure treatments that are widely used. One is called, the earliest one was called prolonged exposure treatment. And that is that you choose it has to be delivered by a therapist, and you choose with your therapist the most important trauma. Okay, whatever that is, the one that causes you the most problems. We call it the index trauma. And then you go through the index trauma in sessions that are usually about 90 minutes. And you recall what happened, where it was, what you were feeling, and so on. People say, well, you only deal with one trauma. But somehow the brain learns to transfer the other traumas into that normal, miserable memory space rather than the PTSD type of space. And actually, PTSD type memories are coded in the brain differently than regular miserable memories. The second type is called narrative exposure therapy. And with narrative exposure therapy, you make a listing with your therapist, a listing of the traumas that you've experienced, and then you go through them again one by one, looking at what happened physically, what was going on, what the weather was like, what the environment was, my own physical reactions, and my feelings at that time. And you go through these over time, again, usually in 90-minute sessions over, and both of these are usually 12 to 15 sessions. Then the newest exposure therapy is called written exposure therapy. And written exposure therapy, again, takes an index trauma and you write about it. Again, very similarly, we usually have people write in longhand about it, not type it. because they have to think more about it if you write longhand. And again, they write about it. And these are the big advantage of written exposure therapy is it's only 5 exposure sessions. And so it's much, and they're usually about an hour. These sessions are usually 50, 60 minutes rather than 90 minutes. So in my clinical practice, that's the exposure therapy that I use most often. Now, the evidence is that they're about equal effectiveness, but there may be differences that some people we don't know about, that some people might do better with one or the other. These treatments have to be delivered by somebody who knows how to do it and is willing to do exposure therapy. There's a myth both in the community of caregivers and also in many individuals who practice psychology, that people are sort of fragile and you can't do exposure. Our culture encourages us to avoid memories of these things. And so what happens is that sometimes people are, they're depressed, so let's treat them for depression first. Oh, yeah, and they're anxious, let's treat them for anxiety first. Let's stabilize the situation. People who do a lot of PTSD treatment understand, and the evidence supports this, understand that by delaying treatment, you're not going to make the depression better. If the depression is due to the PTSD, just treating depression is not going to make it better. It's going to continue. So stabilization, obviously somebody can't be on the verge of suicide. They can't be, very, very depressed, so they can't participate. But people who with a lot of different symptoms can participate in exposure-based therapies.
And I would assume that it really takes meeting the right professional that can guide you in terms of where the right place to go, whether it's this type of exposure therapy or the other. And that leads me to what I wanted to ask is, what resources are out there? How do we find the right person if we are a caregiver that has PTSD?
It's a huge challenge.
Mm-hmm.
First step, though, is to talk to your family doctor and getting on some of the medications that have been, as I described, mostly the antidepressant medications, is a good step in treatment of PTSD. And then trying to find a therapist that you have the money to pay for. Most psychologists who do this be in private practice. Charges are very high, but there may be some community agency. It doesn't have to be a psychologist if the person is trained. It could be a social worker or a mental health oriented OT or anything. We are doing studies on how to teach paraprofessionals. We've completed one study, again, a small randomized controlled trial using narrative exposure therapy. And we're just writing that up for publication with caregivers of children with neurodevelopmental disabilities. And we found a very effective that narrative exposure therapy delivered by eHealth by paraprofessionals was very effective. We supervise our paraprofessionals very carefully in my research group. It's important to do that. And it's not something just to undertake lightly, but it's possible that we're trying to do more studies in that area, applied for grants for that, and we're trying to make it more available. Eventually, we hope to make it available through one of my spin-off companies is called Strongest Families, which is a not-for-profit, but it currently does not offer PTSD intervention, but that's where we might place it afterwards. It's hard for a caregiver to get assistance, so they're going to have to really make a real effort to do it.
Well, we're certainly hoping with this podcast and the other resources that the Ontario Caregiver Organization has, that we can sort of help at least sort of start pointing people in the right direction and have the right questions to ask. Could you expand a little bit more on the cognitive behavioral approach that you have and how it has specifically helped you to connect with caregivers?
Yes, well, the cognitive behavior therapy is a very broad term describing an approach to therapy, which is more skill-based and more science-based than typical psychotherapy. So when I see a client in my practice, you take a history like another psychotherapist might do, or another psychologist might do, and then what you do is I try and figure out, well, what's the problem? And I know, because I know the literature really well, I know, well, what treatments tend to be most effective with that type of problem. So, for example, with anxiety, exposure of various sorts, even if it's not a PTSD, but exposure is really important. Facing, just like your mother used to say, if you fall off your bicycle, you got to get back on. It's easier said than done, but not avoidance. Not avoiding situations is usually the most important thing. And we also teach people different ways of thinking about things. So instead of saying to yourself things like, oh my God, I can't deal with this. It's just too difficult. I don't know what I'm going to do. It's just overwhelming. That's what we call catastrophizing. That's a cognitive style, a way of thinking that's usually very unhelpful. So we try and teach people more of a problem-solving approach. Okay, just relax, Pat. Take it easy. We faced this problem, similar problems before. What is it? What is the issue? What can I do next? Yes, I'm pretty good at doing some of these things. I'm not perfect, but I can manage it. Yeah, let's see what are the options. That type of thinking is so much more helpful. So that's, again, it's not rocket science, but some ways it's harder than rocket science to actually implement these things. But that's what a cognitive behavioral approach does. Try and problem solve, try and figure out what might be effective in this situation. Sometimes it involves changes in behavior. So, for example, very often when people we use a strategy called behavioral activation. We get people to do more things. Very often people avoid doing things that they used to enjoy when they're feeling anxious or feeling depressed. So we get them to gradually, small steps, one step at a time, to try and get back into doing things that are helpful for them. That's very difficult when you're a caregiver because your time is so limited, but even small steps in terms of doing things that you enjoy are very important. For example, in the area of depression and feeling low.
Is this sort of your focus for 90-second caregiver as well?
Well, with 90-second caregiver, we give small we describe issues and we give small encouragements of how to do it. We give very specific encouragements of what to do differently, and that's why we developed this 90-second caregiver and are distributing that through the Ontario Caregivers Organization.
Great. Do you find that caregivers have a hard time talking about mental health and their own personal experiences with it?
I think we all have a difficult time. And yes, the caregivers are, by nature and by situation, are focused on somebody else, the person that they're caring for. And it's very often that they don't want to talk about their own needs and their own mental health problems. But I think it's a problem that is getting better. We talk more about mental health now than we did, 15, 20, 30 years ago. But it's still a problem. And I think the focus of caregivers is on the person that they're caring for. And that's why they don't want to talk about themselves so much. They also may fear that, if I start talking about myself, if I start thinking about my own problems, I will fall apart. I will not be able to to care for my husband or child or friend or mother or father or whatever. So I think it's very important to understand that the mental health, the well-being of the caregiver is really, really important in terms of moving forward. Now, some people would say, well, yeah, all we need is more resources. And absolutely we need more resources. Caregivers are the backbone of the health and social system. Without caregivers, the whole system would totally collapse in an instant. But we also need to focus attention and focus our own attention when we're caregiving on our own well-being.
It's that whole analogy you had of putting on the oxygen mask.
Put on the oxygen mask first for yourself.
Yeah, it makes absolute sense. You did mention that, of course, that if someone, a caregiver that's listening, perhaps suspects that they might be dealing with PTSD, that they should speak to their family doctor.
Absolutely.
Is there any other advice that you might have someone that finds themselves in this situation or thinks that this might be them?
Well, I think that it's important to work with your family doctor to try and get care. As I said, the SSRIs are very helpful, but these small steps to stop avoiding your feelings and reflecting on them. We don't have any data on things like journaling on one's own and seeing if that's effective. We don't have any information, and nobody has done the research to try and figure out if that works. But that makes sense, and to try and gradually face up to the memories that have been so disturbing for you, but do it very, very gently and very gradually. Well, one of the most natural things to do is to try and use alcohol or cannabis or other drugs to try and avoid the thoughts and feelings and with PTSD. Unfortunately, they don't work and they make things much worse. So I would strongly recommend that people not drink or use cannabis in order to avoid. Nothing wrong with having a drink or two once in a while, but don't use it to get away from the feelings that you have from PTSD.
That's great advice. Thank you so much. Dr. McGrath, we thank you so much for being on the podcast today. We really appreciate your expertise and the information that you've given us, and we really hope that our caregivers will find a lot to take away from this. So thanks for being here.
Thank you.
Thank you for listening. We hope you enjoyed this episode. You can access more details about support services on our website, ontariocaregiver.ca. Until next time, I'm Michelle Jobin, and you have been listening to Time to Talk, a podcast for caregivers. We hope you have a wonderful day.